So thank you so much for inviting me to speak today to the Society of Echocardiography here in Pakistan. I'm going to speak about the echocardiographic evaluation of tricuspid regurgitation. These are my disclosures. The echocardiographic tasks for evaluating TR include quantifying the severity, defining the etiology, determining right heart pathophysiology, and then determining the anatomic eligibility for device therapy. And we'll try to cover those in the next few minutes. So when we're talking about quantifying severity of tricuspid regurgitation, we're really talking about determining the outcomes of the disease. We know that after adjusting for a variety of different comorbidities, that tricuspid regurgitation remains a predictor of outcomes. And this was a beautiful meta-analysis of 70 studies, which adjusted for, as you see, the comorbidities that are commonly associated with tricuspid regurgitation, including mitral regurgitation, ejection fraction, and pulmonary hypertension. And tricuspid regurgitation is really not an innocent bystander, but rather a determinant of outcomes. We, in fact, know that with every grade of tricuspid regurgitation, mild, moderate, or severe, that over the long term, there is an associated adverse outcomes with even mild disease. When we look at how outcomes in a variety of other disease processes, such as heart failure with reduced ejection fraction, we see that for every increase in effective regurgitant orifice area or increase in regurgitant volume, that there is a continuous hazard for an increase in mortality. And so, although that increase in mortality seems to plateau with when you're looking at regurgitant volume and vena contracta width, it does not plateau with regurgitant orifice area. And therefore, even mild in this study, regurgitant orifice area is associated with adverse outcomes. So it really is important that we determine regurgitant orifice area. And so by quantitation, the guidelines suggest that we use proximal ice velocity surface area. And that's obviously by reducing the baseline and therefore the Nyquist limit. You can see that there's a shell of regurgitation as you approach the regurgitant orifice. And so that proximal isovelocity surface area there then gives you the regurgitant orifice area when doing the calculations. The problem is that as you see with this biplane image, the regurgitant orifice for tricuspid regurgitation is almost never circular. And therefore, it's hemispheric, showing, and in the biplane image shown here, you can see that it's much wider in one dimension than it is in the other. And consequently, because the orifice is elliptical and not a circle, the PISA tends to underestimate the severity of the regurgitant orifice area by up to 40 to 50%. And although it's easy to measure, it is also not validated for multiple or temporally variable jets, not accurate, therefore, with the non-circular complex orifices, and needs to have flow correction and angle of the leaflet correction in order to actually generate an accurate regurgitant orifice area. And so by echocardiography, we now have three different methods that we are attempting to use in the various trials to quantify disease. One is obviously the PISA, which we know underestimates, but two is the color Doppler vena contracta area. So we're using a 3D color Doppler area more and more in order to quantify disease, showing again the underestimation of PISA. And then we use a quantitative Doppler measure where we're quantifying the annular area either by two-dimensional methods or by three-dimensional methods, and then using a quantitative Doppler. Other investigators are using full three-dimensional echo to quantify both the diastolic and systolic stroke volumes. And so the new method of volumetric Doppler will indeed probably be used more and more. Now, we also learned that the patients that are coming to us with severe symptomatic disease are being diagnosed very late. And that's why we extended the grading scheme to massive and torrential, because again, the outcomes we know are have a continuous hazard of adverse survival, of increased mortality as you increase the regurgitant orifice area. And so massive and torrential now is the range where we ended up seeing most of the patients presenting. Now we're seeing more and more moderate and severe disease. But because those patients were underdiagnosed, we needed to extend the grading scheme. Now, this grading scheme has been shown using the vena contracta diameters, as well as using effective regurgitant orifice area, to be associated with adverse outcomes. And so we now know that there's more and more evidence associated with the extended grading scheme in native disease, but also with post-transcatheter interventions. These are three of the studies, two of them early on, that ended up showing that baseline massive and torrential disease was indeed associated with adverse outcomes. And then, of course, the Triluminate study, both in the early feasibility and the randomized controlled trial, showed that with increasing baseline severity of disease, there was a reduction in the ability to get to moderate after the TEER device, the transcatheter edge-to-edge device. Now, remember that this is not true for the replacement devices. Efficacy here was the same for all baseline severities of TR. And so the replacement devices don't actually care how severe the baseline TR is. They are able to reduce to moderate or less in almost 100% of patients. Now, because of the graded response for the TEER devices, the two European guidelines have mentioned the use of the massive and torrential grading scheme, with the EACVI multimodality imaging guidelines suggesting that we use the increasing grades of severe, massive, and torrential when evaluating patients for transcatheter device therapy. So the second task for ECHO is to define the etiology of tricuspid regurg. And we now have multiple, this new grading scheme where we have two different subcategories of secondary disease, the atrial secondary and the ventricular secondary. And these are defined by echocardiographic parameters. Now, pacemaker-related disease has been taken out of primary disease and is its own category, since the pacemaker device itself may impinge not only on leaflets, but also on subvalvular apparatus. And so these are examples, echocardiographic transthoracic echo examples of primary tricuspid regurgitation, congenital disease, endocarditis, flail tricuspid valves from biopsies. So this is again, we see prolapse as well as a primary disease, and then carcinoid, as you can see here with the thickened and immobile leaflets causing both stenosis and regurgitation. These are both transthoracic and transesophageal echo examples of cardiac implantable electronic device or pacemaker related tricuspid regurgitation with adhesions to the leaflets, but as also adhesions to the subvalvular apparatus and even perforation of papillary muscles we've seen, causing adverse tricuspid leaflet motion, so immobility of the leaflets, and tricuspid regurgitation. Now, when we're looking at defining atrial and ventricular secondary disease, that you can see in these diagrams, and this comes from a recent review in the New England Journal of Medicine, that the atrial secondary disease is often characterized by a discordance between the atrial dilatation and the ventricular size, so that the right atrial size is significantly larger than the right ventricular dilatation, and that in ventricular disease, the opposite is true, where you have a much larger ventricle and often RV dysfunction that ends up defining that disease. And so when you look at ventricular secondary disease due to post-capillary pulmonary hypertension, again with a conical shaped RV and more marked RA dilatation, similar to right the atrial secondary disease versus the ventricular secondary disease due to pulmonary hypertension, then you can see clearly the difference in right ventricular and right atrial sizes. And the reason why it's important is that there are differences in outcomes associated with atrial secondary disease, which tends to have much better outcomes compared to ventricular secondary disease. And indeed, amongst the different types of ventricular secondary disease, again, a graded response that you can see here to cumulative survival, with the worst outcomes in those patients with pulmonary arterial hypertension. We've attempted, this is through both the PCR tricuspid focus group as well as the tricuspid valve academic research consortium, to devise various criteria, echocardiographic criteria, to separate out atrial from ventricular secondary disease. But we're finding more and more that probably the most important characteristic of the differences in the morphology is indeed the end systolic right atrial to right ventricular area or volume ratio of about 1.5. And that was recently shown in this study looking at patients who had had transcatheter replacement repair device, showing that that ratio of the RA to RV area of greater than or equal to 1.5 when in combination with a TAPSE of less than 17 was able to define different disease categories that had different outcomes. And so we do believe that we may be able to simplify the definitions of atrial secondary disease. Now, the third task is to determine the right heart pathophysiology. This becomes extremely important in determining outcomes for transcatheter device therapies as well as surgical intervention for tricuspid regurgitation. And with echocardiography, we have a number of different measures of not only size, but also function. And that includes TAPSE, which is our traditional measure of longitudinal function, as well as fractional area change, which actually measures more not only longitudinal, but circumferential shortening. We also have a systolic TDI and longitudinal strain, those also measuring longitudinal shortening of the RV, typically the free wall. But what we're using more and more is three-dimensional volumes to characterize the ejection fraction of the right heart. And toward trying to define normal from abnormal, the TVARC definitions have used normative data that has been recently reported using worldwide echo data to define what we believe is mild, moderate, and severe dysfunction using a variety of different parameters. And we hope that those parameters may assist in the research that's being done in outcomes for tricuspid regurgitation. Remember that almost all of these simple measures that we do every day, fractional area change, TAPSE, and of course RV strain, will determine outcomes for tricuspid regurgitation. And again, defining cutoffs for mild, moderate, and severe, and these are all definitions of any disease, even mild dysfunction, may help us determine outcomes. But really the RV pathophysiology is very, very complex. And so we know that it is three different separate mechanisms of the bellows effect, where you have the free wall moving toward the septum, and that's more circumferential function, as well as the traction on the free wall. So there's ventricular interaction that allows the LV and the RV to work together, and then the contraction of the longitudinal fibers, which has been our traditional measure of TAPSE as well as S prime and free wall strain. But it's a much more complex contraction pattern than just a simple measure. We know that indeed that pulmonary hypertension will also, as I showed you before, determine outcomes, and that the RV happens to be very sensitive to afterload. And so what we now believe may be an important measure of RV function is the way that the RV responds to that afterload in a measure called RVPA coupling. And so there are a number of different ways of measuring RVPA coupling. The simplest and the most frequently used is just measuring TAPSE over pulmonary artery systolic pressure, TAPSE over PASP. And in this study, looking at conservatively treated patients, the cutoff of 0.31 defined those patients with adverse 5-year outcomes. In addition, in the TriValve registry of TTVI, and this is mainly TEER devices, edge-to-edge repair, we see that the cutoff for adverse outcomes is 0.41 millimeters per millimeters of mercury. And so we do believe we have the ability to determine outcomes using RVPA coupling. But remember that even with baseline abnormal function, what meta-analyses have shown is that after transcatheter device therapy, there will be a reduction in that function because of the increase in effective afterload. But there's also an associated increase in forward stroke volume. And studies have suggested that the decrease in function seen after TTVI does not determine outcomes, but rather the increase in stroke volume will improve outcomes. So the last task is, of course, to determine eligibility for transcatheter device therapy. There are multiple CE mark approved devices in Europe and, of course, 2 now in the United States. And so to determine the anatomic eligibility for device therapy, we are frequently using echocardiography. This is the new guideline for screening for structural valve procedures with the added green level of imaging, which is the deep esophageal view. This is some of the anatomic restrictions that we have for leaflet approximation, as well as for annuloplasty devices. These are all published in the Eurointervention article from the PCR focus group. And we also understand that the orthotopic valve replacements tend to have the least number of restrictive anatomies that can be treated with this device therapy, but that the greatest amount of RV reduction in function is seen with this device. And so we are still learning about those restrictions. And so in sum, we know that the current state of knowledge is very great. Within the last 10 years, we've learned so much about quantifying disease, about the etiology of the disease, about right ventricular function, and also device therapy. But there are a number of different knowledge gaps for which imaging will be key to understanding. Thanks for your attention.
Thank you very much. Thanks, Dr. Rebecca. It was really excellent, outstanding talk. If there is any question.
Yeah, Dr. Rebecca, thank you very much for sparing your time at this odd hour and talking about not a forgotten but rather less well-studied chamber and the valve. So thank you very much. My question is about the lead-induced tricuspid regurg. Generally, we see a milder and not severe enough. But if there is severe TR due to the lead-induced, how would you tackle that?
Oh, that's such a good question. So what we try to determine by echocardiography, and every now and then we can also use CT scan, is whether or not the lead is actually the cause of the tricuspid regurgitation. And if it is possible to remove the lead, we've been able to see some reduction in tricuspid regurgitation to the point where we may not need to treat. And that's obviously if the TR is severe. But there are a number of patients where we feel it's dangerous to remove the lead, and those are the ones where the lead has been in place for more than 7 to 10 years. Now, typically those that are in place about 1 to 2 years are very easy to extract. But beyond that, you have to have an expert extractor in order to remove the lead. If we can't remove the lead, then we do see whether or not we can still place an edge-to-edge device on the leaflets that are not being affected. And if that is not possible, then we consider jailing the lead with a transcatheter replacement device. It also a not perfectly safe solution, because if you get an infection of that lead, then they tend not to be removable and therefore increase the risk of a poor outcome. So our algorithm is to first define whether or not it's affecting the tricuspid. If it is and we feel we can remove, we now are removing the transvalvular leads. And if they can't be removed, then we're still considering transcatheter therapies based again on anatomy.
Thank you.